Assalamu alaikum, it's your boy Missing Two Tendons, and welcome to the Fibrotic class of ILDs, the biggest, densest, contains the most diseases class. But the good news is, don't worry, if you study this part in like a logical manner, it's actually piss easy. Not only that, most of the questions will come from this part. The rest are relatively low yield. I'm only going to teach them just for the sake of completion. But yeah, don't worry, inshallah, hopefully you have fun. And aslan, in this class, you have some fun diseases. Fun, in relation to like other lung diseases. Yeah. Okay, so there are 6 diseases under this category. These are going to be IPF, NSIP, BOOP, pneumoconiosis, and drug-induced, radiation-induced fibrosis. What we're going to do is we're going to dissect through each one and understand them more and just really identify the key high-yield shit that we need to know. Okay, so diving into IPF, also known as idiopathic pulmonary fibrosis. Okay, so the first question is, what is idiopathic pulmonary fibrosis? Well, IPF is simply, like the name suggests, fibrosis of the interstitium without any known or without any underlying cause. This disease, as you're going to hear it a lot of times, is associated with something called a UIP histological pattern, which we're going to learn later on. But the key idea here is that basically the lung undergoes fibrosis, but no one knows why. So if someone asks you what is the cause of IPF, and you mention any other cause other than unknown, you actually deserve to lose the mark, because really this is the core aspect of IPF. So the most important thing you have to do before diagnosis is to rule out any underlying cause. This is exactly why history is so important. You will ask about the past medical history to kind of see if the patient's taking any medications. You want to ask about any exposure to radiation. You want to really dig deep to see if there's any underlying cause. If there isn't, then you can basically diagnose the patient with IPF. In terms of the epidemiology of IPF, really not very high yield, if I'm being honest, but just so you know, affects the older population, usually over the age of 60, and affects men more than females. What is the name of the histological pattern seen in IPF? This is really the core of this lecture, because what we see in IPF is something called usual interstitial pneumonia, or UIP. Now, what is UIP? UIP basically is patchy interstitial fibrosis in the early stage, eventually turning into honeycomb fibrosis. Just because this is so important, let me explain further. When we say patchy interstitial fibrosis, what we mean is that if you take a biopsy of the lung, you will see some areas where the lung architecture is normal and other areas where there's fibrosis. So it's patchy. The fibrosis is there in some places and is invisible in other places. This is in the early stage. As time goes on, as fibrosis continues, what will happen is the fibrosis will reach a point where it's so much that the alveoli can't handle it and they will collapse. So you'll have collapse of the alveoli. You're going to have hyperplasia of the type 2 pneumocytes. And we call this kind of late stage shenanigans as honeycomb fibrosis. I think you're going to see some examples of honeycomb lung in radiology. You won't forget it once you see a good CT scan. So early stage patchy interstitial fibrosis, late stage honeycomb fibrosis. This image is what's on her slides, but I don't think it's very good at really showing you the patchy interstitial fibrosis. So what I'm going to do is I'm going to show you a slide I found online. You can see in green, that part of the lung is relatively normal, okay? So it looks kind of normal. There doesn't seem to be a lot of fibrosis. But then when you look at the red part, you can tell there's a shit ton of collagen there, which is not supposed to be there. The whole kind of thing is very thick. And I'm not really good in pathology, so if I can pick it up, then you guys have no excuse on not to pick that up. This is a good example of patchy interstitial fibrosis. So, early stage of IPF, the fibrosis is usually seen subpleurally, and as time goes on, it will eventually extend to the rest of the lung, and you're going to have the classic honeycomb lung fibrosis. Signs and symptoms of a patient with IPF. These patients usually present with progressive dyspnea. This basically tells you that the fibrosis gets worse with time, and dyspnea makes sense because, like we said in the introduction lecture, it's a primary hallmark of many ILDs. These patients also present with a chronic non-productive cough. And by the way, these symptoms are more of the early stage fibrosis. We're not really diving into the complications of IPF. I'm going to leave that for a later question. In terms of physical examination, you will find crackles. Again, these make sense just because you have that kind of fibrosis, you have that kind of interstitial, you have that inflammatory shit. So the lung is not as before. So when you take a deep breath, you gotta put in some pressure to kind of expand the lung, the compliance. This leads to that crackle. Apparently the books call it Velcro-like. I don't know. Just remember it, I guess, as Velcro-like. In terms of the diagnosis or the gold standard test for confirming IPF, as we said, number one, rule out the underlying cause and then take a surgical biopsy. Once you do the biopsy, if you see a UIP, you can confirm the patient is IPF. Now, this is the sad part of the disease. Unfortunately, the prognosis of IPF is not that good. Okay, it's shit. I'm gonna be honest with you. It's actually really, really bad. I think the median survival rate is like 2 to 3 years. And I'm gonna use this point to kind of just elaborate further in how can fibrosis lead to death in general. And you can really apply this to most of the ILDs that we're gonna cover today. So, the lung undergoes fibrosis, okay? That makes sense. But what you should know is that with fibrosis, you have pulmonary artery hypertension. And this will lead to cor pulmonale, and this will lead to congestive heart failure, and then that will lead to death. So this is kind of the cycle if you basically, if a lung undergoes fibrosis over the long term. And like we said, the prognosis of IPF is really, really bad, and the treatment is basically if the lung has IPF, the lung is gone. So the only treatment is lung transplant, and I guess that's more kind of makes sense if the patient is younger. Once the patient goes over 60, I guess you have a lot of comorbidities. So the question is, but I know if a patient has IPF, they put on the lung transplant list just because there's no other treatment. Okay, so moving on to NSIP. NSIP stands for non-specific interstitial pneumonia. So this one is another idiopathic kind of interstitial pneumonia. The difference between that and IPF is, okay, so first things first, whilst it's idiopathic, they believe it's possibly autoimmune in origin. But really what I want you to kind of think about NSIP is to always kind of compare it with IPF in the way that the main difference is the prognosis and the treatment. The good news about NSIP is that the prognosis is very good because it has very good response to steroids. And of course, if I'm going to mention steroids, I have to leave an honorary photo of the great Lance Armstrong who freaking shammed the sporting community with his blatant use of performance-enhancing drugs. But seriously though, NSIP has very good response to steroids, so we can use them and kind of prevent the end-stage fibrosis as seen in IPF. Another disease is something called BOOP, or B-O-O-P. Now, I have no idea why they call it that. Apparently. Okay, so right now the new term for BOOP is cryptogenic organizing pneumonia. The old BOOP used to stand for bronchiolitis obliterans organizing pneumonia. And I can tell why they changed the name because the previous name sucked. But the abbreviation is pretty chill. But like from the name, you can see bronchiolitis. So what is it? Basically, all I want you to remember is this is a disease where you have damage to the bronchioles. Another thing that I want you to know about BOOP is the histology. So these patients present with something called a polyploid plug of loose organizing connective tissue. There's a lot of pathology words, so I'm just going to describe it in what I understand. It looks like a big pink swirl, okay? So if you look at the alveoli, if you look at the bronchioles, you're going to find this kind of connective tissue, but kind of loose in this big-ass pink swirl. That's classic for BOOP. I really doubt that they're going to bring this in an exam, but you know how AU University is. You can never expect anything. Again, going back to the prognosis of BOOP, it is pretty good. Every time I say BOOP, I kind of die inside for a little bit, but who cares? This is for science. And previously, like in NSIP, the treatment for BOOP is steroids. Okay, so now we move on to pneumoconiosis. I hope I'm pronouncing it right. I hate this word. I can never spell it without auto-check, so that's cool. Pneumoconiosis is basically a group of diseases that fall under, again, it's very similar to ILDs. It's a group of different diseases that all fall under the same category. And there are three main diseases that she wants us to know. Well, not us, you guys, because I already took the course. There are three diseases that you need to know. This is going to be cold workers pneumoconiosis, also abbreviated as CWP, silicosis, and asbestosis. And before I start, I just want to say, after NSIP and BOOP and a bunch of different diseases that we're going to take in third year, it's refreshing to finally find a disease where the name just makes sense. And this is one of them. Now, in pneumoconiosis, the presentation of symptoms is different, is varied. Patients may present with acute bronchitis and pulmonary edema, or they may present with pulmonary fibrosis, or they may present with occupational asthma, or they may even present with allergic alveolitis. The idea is that it's not one presentation for all patients, it's varied, but for the purpose of this lecture, we obviously are going to focus on the pulmonary fibrosis presentation. Pneumoconiosis in general, they all have a general pathogenesis. Very similar to what we took in the intro lecture, but I'm going to re-elaborate it, number one, for kind of like commitment to memory, and also just because I'm going to go a bit more specific. Pneumoconiosis in general, they all kind of begin with inhalation of some sort of mineral dust. Obviously, this is chronic inhalation of a mineral dust, like coal or silica or asbestos, doesn't matter. You basically inhale a lot of this dust. Macrophages, it's going to reach the alveoli. The macrophage is just going to do its job. The macrophage is going to see shit and it's going to eat it. Unfortunately, the body doesn't have a way to break them down, so the macrophages basically kickstarts the inflammation process. You have a lot of fibrogenic shit, like we said, TGF alpha, TGF beta, and basically the end product is fibrosis. This is the same for co-workers pneumoconiosis, for silicosis, and for asbestosis. A very general pathogenesis, great way to kind of basically merge three stuff in one. Two important information that will make you suspect of pneumoconiosis when taking history. The first, biggest, most important is occupation history, the occupation of the patient. This is why in Pro, they taught us when we take history, you ask about past social history, which I am sure most of us ditched or most of us forgot during OSCE. We never really placed importance on that. But this is really where it comes in. You gotta ask the patient, what do they do for a living? Because you may be taking your history, maybe you're thinking of COPD, whatever. Then you ask the patient, where do you work? And he will tell you, I am from Arar, I work in the mines. Straight away now I'm suspecting something completely different. Always ask about occupation, and usually in the exam, because I know you guys are still focused on the exam, this is where usually the biggest clue will be in the question. War zone history, to be honest, I memorized war zone as war zone. It was until a few days ago where my friend asked me, why war zone? And then I kind of discovered, holy shit, this is actually important. Basically, a lot of times, especially for the American military, when they came to the Middle East, turns out we have a shit ton of sand. So sand is an example of a mineral dust. So a lot of them got kind of silicosis, and they even called it the desert slum. So even though technically in the military it is an occupation, ask about, did they go to any war zones? Have they went to the Middle East? If you're basically doing your shit in America, these are two important information that will allow you to suspect pneumoconiosis from the question stem. So let's dive right into cold workers pneumoconiosis, or CWP, which is what I'll refer to it because it's too wordy. Again, very simple. This is simply pneumoconiosis caused by inhalation of coal dust chronically. Patients, the progression of cold workers pneumoconiosis is very important. These patients will begin with something called anthracosis, and then they're going to develop simple cold workers pneumoconiosis, and then complex cold workers pneumoconiosis. So what the frick is anthracosis? Well, don't worry, I'll tell you. Anthracosis is the first stage of CWP. These patients are silent. This is a benign stage. It is asymptomatic. If you do a lung function test, everything's going to be normal. The only difference is the histology. Because when you take a histology of someone in the anthracosis stage, you will find carbon within the macrophages. So they call it carbon-laden macrophages. And here's the histology of someone in anthracosis. You can see you have some black macrophages. Now, I'm not being racist. That's because they're full of carbon. These are called carbon-laden macrophages. Again, patient is absolutely fine. He's asymptomatic and is benign. Let's say you continue. Man continues working in the coal mines for more time. Eventually, you're going to develop something called simple cold workers pneumoconiosis. Now, instead of just carbon-laden macrophages, you have something called a cold macule. This can be seen grossly. I put two images from the slides, and they are around 1 to 2 millimeters in diameter. Basically, what you're going to see is you're going to see fibrosis, so there is some collagen, and within the collagen, you're going to find some carbon-laden macrophages, a lot of them. So this is simple CWP. Still purely histology, maybe a bit of morphology, but you wouldn't know because the patient is still alive. You didn't do an autopsy, but the idea here is patient is still asymptomatic, LFTs are normal, he just be vibing. And then you hit complicated CWP. Complicated, basically, this is where the lung dysfunction happened. This is where patients will present with symptoms. This is where patients will basically have some sort of manifestation. In terms of findings, if in someone with complicated CWP, apparently is the presence of cold nodules. Think of those cold macules, but much larger, and obviously lung dysfunctions or abnormal LFTs, etc. Late stage complications, again, like I said, very similar to most of them. Initially, you're going to have changes in the pulmonary function test. Over time, you're going to have pulmonary artery hypertension, then cor pulmonale, then congestive heart failure, and then, bye-bye. Caplan syndrome, okay, so this is kind of random. It seems like it's coming out of nowhere, but it's actually pretty important. Caplan syndrome, very simple. If a patient comes to you with a combination of rheumatoid arthritis, which you're going to take an MSI, but don't worry, rheumatoid arthritis plus CWP is Caplan syndrome. Best. Now we're going to go into some relationships between CWP and a bunch of shit. First question is, what is the relationship between smoking and CWP? Well, if a patient has CWP and they smoke, they have an increased risk of developing COPD. That's the first thing. Second thing is, what is the relationship between CWP and COPD? Well, a lot of CWP patients will develop some form of bronchitis, so some form of COPD. And actually, I think if we had the same PBL, because we had a PBL case, and yeah, of course, they botched it, as always. But in that case, the patient was exposed to coal, and he was smoking, and he presented with classic COPD pattern. This is a good kind of reminder for me of the relationship between the two. What about the relationship between cancer and CWP? Well, alhamdulillah, thankfully, there is no correlation. But as you can see, later silicosis and asbestosis, that's not exactly true anymore. Finally, what part of the lung is mainly affected? In coal, think of the upper part of the lung. So coal is going to be upper part of the lung. This is going to be, again, a good differentiating factor between the other pneumoconiosis that we're going to study. And speak of the goddamn devil, there we go, silicosis. Now, silicosis, again, like the name suggests, is pneumoconiosis caused by the inhalation of silica dust. Now, what occupations are linked with silicosis? Well, think of miners, think of sandblasters, think of maybe military personnel who had to work in the Middle East or in a desert environment. All these are kind of like basically red question marks for silicosis. Chest x-ray findings, oh my God. They love this. They love to ask. This is so high yield. USMA love to ask this. Al-Faisal loves to ask this. I love to ask this because it's so easy to remember. There are three key findings. Number one, eggshell calcification of the hilar lymph nodes. The hilar lymph nodes on the side of the lung next to the heart, you're going to have something called eggshell calcification. Kind of easy to remember because a lymph node kind of looks like an egg. So if you think of calcification of the outside, eggshell. That's number one. If you look at the upper part of the lung, you might find these small nodes. So eggshell calcification, small nodes, and the third one, over later periods of time, you're going to have diffuse fibrosis. So you're going to see signs of fibrosis, scarring, and all that kind of shit. So these are three findings. Please commit them to memory. These have a very high chance of coming in either the ASCII or an MCQ. I don't know. Now, what's the relationship between silica exposure and silicosis? I don't know. This question sounds really dumb and retarded because, silica exposure leads to silicosis. Yes, that's true. But I want to add one point. Silicosis happens with a 10 to 20 year lag. So تخيل someone has exposure. They won't get silicosis until maybe 10 to 20 years after that happened. But then once kind of silicosis kicks in, stopping the exposure won't reverse the disease. Once it started, it has started. So that's just something you need to be aware of. Histological findings of silicosis is actually pretty cool. The first thing is when you see the alveolar space, you're going to find a lot of macrophages, and these macrophages will appear a bit brown. We call these hemocyaridin-filled macrophages. That's number one. And number two, when you shine light on the biopsy, the silica particles will kind of shine white. So in the first image, the one on the left, you can see the black arrows. They point to the brownish pigment of the hemocyaridin macrophages. And on the right, you can see those white sparkly stuff. That's silica, by the way. I zoomed up this because I'm a nice guy. I'm trying to make sure the histology doesn't confuse you. Again, the big image on the left is the hemocyaridin-filled macrophages inside the alveolar space. That's number one. Upper image on the right is the silica. Lower image is the nodules found in the upper part of the lung. 3 chest x-ray findings, 3 histological findings. Treatment of silicosis. Remember in the introduction when I spoke about the general pathogenesis and I gave an extra question of why do we have, when I asked about what molecules, the immunological molecules, we said TNF alpha, TNF beta, right? Well, turns out that we can give them TNF alpha inhibitors and that will stop the fibrosis. I think that's pretty damn cool, to be honest. Moving on, relationship between TB and silicosis is actually important. Actually, they found that silicosis increases the risk of TB. So if you have identified your patient with silicosis, make sure to give him prophylaxis against TB because they're at high risk of developing TB. Finally, I know, keep going. The final disease within the pneumoconiosis category is asbestosis. And before we dive into asbestosis, let's have a little chat about asbestos. Asbestos, bro, like back, I guess maybe in the 90s or the 70s, I don't know, back in the olden days, basically, the world fell in love with this material because apparently it was lightweight, and in the West, it was a good insulator. So what we did is we would go, not me personally, but like, I guess my ancestors, what they did is they used asbestos as an insulating material. So it was all over houses, it was in shipyards. Everyone loved asbestos until we realized, oh shit, we're dying from it, so we better stop. Why I want to mention this is basically, okay, so that was just kind of like a background history. Asbestos comes in two forms, serpentine and crocodolite or amphibole, whatever. The difference between the two, they are both fibrogenic. They both lead to fibrosis. But the major difference is the serpentine form is not carcinogenic. The crocodolite is. So serpentine, fibrogenic but not carcinogenic is the most common form. Crocodolite or amphibole, it is fibrogenic and carcinogenic. And this is relevant because asbestos is heavily linked with cancer. Now, asbestosis leads to four conditions. Obviously, the first one is asbestosis or the interstitial fibrosis, the fibrosis of the lung. This is the one that we know because we know it's a pneumoconiosis. Number two, plaque formation on both the pleura and the diaphragm. So you're going to find these ugly yellowish plaques on top of them. That's number two. Number three, mesothelioma. I'm not sure if you took the lung cancer lecture yet, but mesothelioma, like the meme, is basically cancer of the pleural coverings, of the pleura. And finally, lung cancer. These are the four conditions caused by asbestosis. Signs and symptoms of patients with asbestosis, again, you have dyspnea, especially on exertion. You have chronic productive cough, again, like the primary hallmarks of most ILDs. The histological findings is interesting. You find two things. Like in silicosis, you also find your classic hemosiderin-laden macrophages, but you also find the asbestos bodies. You see that cell on the right with the kind of weird shit inside it that looks brown and like a tapeworm from POD? That's an asbestos body. Remember how I said macrophages, when they inhale mineral dust, they can't break them down? Well, these brown tubular shit is asbestos bodies. Again, here's another biopsy from the slides. You can see the big blue circle. It's highlighting those asbestos bodies, these long cylindrical shit inside macrophages. That's number one. Number two, just like in silicosis, you have your classic hemosiderin-laden macrophages, and they're the ones on the top right. What part of the lung is mainly affected in asbestosis? Well, lower part of the lung. What affected the upper part of the lung? Yes, CWP. If you said CWP, you're freaking badass and you're amazing. If you didn't, well, you're amazing, but maybe not necessarily badass, you know? Three most important complications of asbestosis. Number one, honeycomb fibrosis. Remember how we said before, the classic kind of thing where you begin with when you have fibrosis, pulmonary arterial hypertension, cor pulmonale, congestive heart failure, and then a whole big oh shit moment. That's number one. Number two, lung cancer. Turns out asbestos, the crocodilite form, is a carcinogen, so lung cancer. And finally, mesothelioma. Yes, like the meme. Well, if you didn't know the meme, well, I guess that's kind of sad.
Attention. If you or a loved one was diagnosed with mesothelioma, you may be entitled to financial compensation. Mesothelioma is a rare cancer linked to exposure.
Asbestos plaques. These are the plaques that we said that are found on the diaphragm and the pleura. I want to mention, if you see an asbestos plaque, doesn't mean the patient has asbestosis. They are sensitive, I guess, but not specific. Other conditions may have that. What are they? Are they asbestos deposited on the diaphragm and the pleura? Well, that would make sense, but actually no. It's basically collagen and calcifications. I know, it's one of those kind of pathology just being retarded kind of things. What is the relationship between smoking and asbestosis? Well, turns out smoking increases the risk. See, even I forget English at times. Smoking increases the risk of lung cancer in asbestosis by 5 times. So it has a synergistic effect on basically ruining your life. This is not for mesothelioma. This is for bronchogenic carcinoma or lung cancer. Again, kind of just to remind you, smoking and co-workers pneumoconiosis, that increase the risk of COPD. In this case, it increases the risk of lung cancer by up to 5 times. Very, very important. Patient comes to you with asbestosis, try to make him stop smoking. And that concludes the pneumoconiosis section. Guys, take a deep breath with me. We're nearly finished. Just 2 more questions. Drug-induced and radiation-induced. Very, very simple. Alhamdulillah, we left it to the end. Like the name suggests, some drugs can lead to fibrosis. For example, bleomycin. We give this in cancer patients. That can lead to drug-induced fibrosis. Amiodarone, I don't know how to pronounce it, bro, but it's an antiarrhythmic drug that can also lead to drug-induced fibrosis. That's why we asked we want to ask about medication history. Very, very important. Don't go around labeling people with IPF. Maybe it's the medication. That's number 1. Radiation-induced fibrosis is basically patients who had radiation before can lead to fibrosis. This is a complication especially seen in cancer patients. So patients may have had cancer that had radiation and come back maybe 5 years later with radiation-induced fibrosis. That's a known and feared complication of radiation. And that's it, boys. We're done. So listen, I'm going to re-emphasize it one more time. This is legitimately the biggest section of the lecture, and I can guarantee you with 85 to 90% accuracy, this is where the questions are going to come from. The rest of the lecture is going to be very short, very low yield. If you don't have enough time, well, obviously, I should have said this in the beginning, but this is a video really to watch and to focus on. The rest of the stuff, really low yield. Most of the questions will come from this section. And by the way, I'm freaking proud of you for reaching this far. I hope this explained all your concerns about the fibrotic class. And I'll see you guys in the next one where we go over the granulatomas, eosinophilic, and the, smoking related. See ya. Peace out.